Good morning, everyone. Welcome to another session of the Endocrinology Grand Rounds. We are extremely proud to have one of our foremost fellows, Dr. Maria Fleseriu. And I'm going to probably stop at that introduction, but I'm not. We are so glad to have her. She's a professor of medicine and neurological surgery and director of the Pituitary Center at the Oregon Health and Science University in Portland, Oregon, member of the board of directors of the Endocrine Society and past president of the Pituitary Society. I want her to do the talk and not to spend an hour on introductions, but she did complete endocrinology training at University Hospital Cebu National Institute of Endocrinology in Romania, and then the Center Hospitalier Luxembourg in Luxembourg. She did her fellowship with us again, just because I'm so proud of that, and has received many national and international awards, including the title of Doctor Honoris Causa by the University of Medicine and Pharmacy, Carol de Villa, and the Clinical Endocrinology Trust Award from the UK Society of Endocrinology. She is obviously a pituitary expert, so it's going to be talking about Cushing syndrome. Thank you so much.
Thank you so much, and it's a pleasure to be here. Thank you, everybody, for listening to this talk. I know it's harder online than live, but here it's so good to see everybody. And we didn't say, but in June it's going to be 19 years, so not 20. So I have to come back to celebrate the 20-year anniversary from finishing the fellowship. And everybody that I have seen, we all look exactly the same as we did before, but I will show you a little bit more. So it's hard when you talk about Cushing's and you have less than an hour what you are going to focus on. So what I have decided is to talk a little bit more about the personalized approach and then review a little bit of the newer data on medication, because this is what's important and relatively novel. They are a lot, and I don't know if your neurosurgeon is online, and there are a lot of developments of surgery, but of course I would be happy to talk about if I get questions. These are my disclosures related to Cushing, research funding for OHSU, and occasional scientific consulting related to the study that you are going to see, that for some of them I work with the eye. So for the fellows in the room, I don't know if you have also medical students on the line, but this is probably the most recent review that we have looked for JAMA. Do we have any changes in how many patients they have Cushing's? And then again, and there are some studies that if you look more, maybe they have high cortisol, if they have diabetes, but do they really have Cushing? So the data is still out and we don't really know exactly confirmation. But overall, what's changing over time is the fact that we realize that a little bit more, so this is of all Cushing syndrome cases, they are ectopic, that we thought they were pituitary in the past. And adrenal Cushing's, clearly it's increasing over time. So when we were thinking that almost 75 to 80% are Cushing's disease, this is decreasing significantly because we know which can make the diagnosis of pathology, but also there are a lot of other causes overall, and still remains majority female, and this was one of the reasons that probably is underfunded as a disease. I don't know, I spent too much time on that. And again, why it's so hard to make a diagnosis is that if you see on the left the more discriminatory features, that it was this patient, and this is from the reviewing Lancet, this is not my patient, this was a patient from Brazil, but I have to say that there are a lot of patients that look like this even now in our clinic, and I'm sure you still see them here, that they are seen extremely late. And this is mostly, and I'm not going to spend a lot of time on the less discriminatory, but if you have more than one feature, so yes, obesity, we can screen at everybody that has obesity, but if they have extra features on top of abnormal weight gain, facial fullness, skin thinning, hormone killing, and of course irregular periods. So when we looked at the data a while ago, everybody had Cushing's. The women were confirmed Cushing's disease. The women were told that they have PCOS for 5 years. So this is something that we can do to make an earlier diagnosis. Why it's important? Cardiovascular disease is the leading cause of death. This meta-analysis is relatively recent if you look at it, and we saw things are getting better, and they are a little bit, but full standard mortality ratio is still 3 with cardiovascular disease the major cause, and I will show you some other data after that, infection and malignancies. So when we look, this is like last year, but I have new data that I'll show. I have worked very close with the Israel Large Registry. I don't know if European countries have significantly better registry than we do, unfortunately. So this is looking at nationwide registry with 600 patients with Cushing's, with huge control numbers, with MET for BMI, MET for socioeconomic status, smoking, and everything. And look at the Cushing's syndrome and cancer risk, significantly higher, and this is the overall one. And then also for adrenal, which again, we thought that this is because it's mild, it's not going to have the same set of complications. Lower number, but again, very well matched. And you can see significantly higher for very long follow-up for cancer. So this is something that we need to think about. Now, this was published last week. When we looked at remission status and risk of cancer overall, as you can see, no remission is significantly also higher risk of cancer, which we knew before for cardiovascular disease, but it shows that it's also for cancer. And the Cushing disease overall, the adrenal was a little bit different. I'm not going to show you here today, but it's in the paper in EG. But also very important to think the comorbidities, and that's why I made the tips for an earlier diagnosis, that the comorbidities, some of them partially recover, and you see here in blue, and I will show you some data talking about personalized treatment, how some of the comorbidities can improve, and we choose one versus the other even for medications. However, there are some that persist, including the psychiatric disorders, cognitively impaired quality of life, significantly decreased lifelong. And of course, the cardiovascular disease, and if you remember, I think I took out the slide, the risk of stroke persists even 5 years after complete remission, even after surgery, so separately for medication. Myopathy, there are some complications that we say they persist. There are some studies now, this is from Germany, that the serum IGF-1 may predict long-term myopathy. And again, it's coming with the idea that can we treat this with growth hormone? And again, I keep it out with the interest of time, and I will be happy to talk about. It's no data, so we know that it predicts myopathy, but it's no data that if you treat with growth hormone, it's going to improve directly. Now, however, if they have growth hormone deficiency, especially for younger women, if it persists and the testing done at least a year, like we said in the guidelines, after, we can definitely do it. And I push the insurance to convince them. How about other complications? So this is a systematic meta-analysis that we did now a few years ago. Time flies when you're having fun. When we looked for the first time, is this risk of hypercoagulability something that we see in some patients that die of pulmonary embolism in our face? Or is this something that we just see the more severe cases because our center is seeing them here? Of course, they're coming to send a second, third opinion. So we looked at 48 studies and we included for the first time everything, including the case series and cohort. We took out overall other type of patients. And short, the odds ratio compared with the general population was almost 18 times. And we compare, and this was without anticoagulation. And then we compare, when we compare it with, I thought the hip fracture, because it's the only one when we were seeing cancer, this is the patient that were asked to see. So I said, let's see hip fracture because everybody gets their anticoagulated. And it was a little bit lower than that, but that pushed to have more anticoagulation overall. So when we looked at our data, this was also arterial. So a lot of the data you see is just venous, so that's why you see lower numbers. But when you look at our retrospective patients of 200 patients for 12 years, the numbers were 18.2, but again, a lot of MIs and other arterial complications too. But if you look, when did it happen? Because this is the only graph I'm going to show you. Most of them were in the 0 to 60 days. And out of these patients, the large majority underwent bilateral atherectomy at that time. This was, keep in mind, 2006, there were no meds. Almost everybody got bilateral atherectomy at that time if it wasn't cured. We couldn't find any predictive factors, which is funny if you look, because then what we said in the guidelines was like, hey, look at that predictive factors that, again, I don't think we have or not. But this is adaptive intermediate, but this is from the new Delphi consensus that was published in the Journal of Endocrinology last week. This was a large international consensus. I was the only one from the US, unfortunately, because if you look at how much they do anticoagulation, and I have to talk to us here to see if you're anticoagulated, everybody with Cushing's, like they're showing up to clinic. I think our practice now is a little bit different, and of course we do the severe cases, but clearly not everybody. So we should consider prophylaxis for all patients with active disease unless contraindication. And being from US, as you can imagine, I added the lawyery stuff because you can't say you have to do it in everybody because then there are going to be problems if we don't, which was very interesting. Because the lead author is from Eastern Europe that didn't think of that, like we were in the past. And then I think that for us, the perioperative management is essential because I think that we're not continuing long enough when they are the events overall. And then the Cushing syndrome in remission, that's an issue that, again, I have to say that I'm not sure that we have to continue for 3 months, but I was in minority. Are there events? Yes. So that we have to look more into detail. But for now, this was published, not in this form, this has been submitted, but this was published last week. If you want to see more, I'll be happy to send you the paper, but I think it's open access. And also, the PGP prevention that we used in all the papers, including the guidelines, which was USP more than 10 upper limit of normal. We have to do prevention for PGP. However, there are data from France saying that it's a higher risk if you really check and do X-rays for some patients, especially with ectopic, even if they have lower values of UFC. So now I'm starting to look at between 5 and 10 upper limits of normal to also do prevention with Bactrim. Usually I use Bactrim. If they are on medication for Cushing's, I found out something about it. And we talked last night about drug-drug interactions. That Bactrim is probably something that I had no clue. But in addition to medications, we need to think more about that. So we switch from, we have to make an earlier diagnosis, and I showed you why it's a little bit complicated. There are a lot of comorbidities that we have to look at. And keep in mind, I haven't shown you all of them. I just gave you a flare of the new data. And now we're going to focus on treatment. And from the first case with Harvey Cushing's described in 1912, we made huge differences for patients. However, as you've seen, there are still patients diagnosed very, very late, but at least in treatment, this is the first ESS in 1963, and then several medications. The first one was approved in 2012. I was the main lead for that study. And then Pasireotide and then Levoketoconazole are approved in Europe. I'm not going to talk about that because they are not approved here, but I will be happy to answer questions. And then Osilodrostat and then Levoketoconazole. We published the 2021 consensus both for diagnosis and management of Cushing with large international consensus. And let's see where we are now. Probably time to update that, but we'll see. So what we said in the guidelines and still stays the same, and unfortunately, I had for a while the idea, and I even gave some talk, can we replace surgery? It's not happening. So especially for Cushing's disease, for the large majority of patients, the pituitary surgery remains the best treatment. We don't have anything better that can almost cure the patients. I don't like cure because, they have very high rates of recurrences. And then if they have persistent disease, then we use medical therapy. And I'm going to focus again the role of medical therapy, a little bit about each drug, but also when we should use this versus the other. So we looked for this review in Nature Endocrinology a little bit more in detail than the guidelines itself, how to use medications and to think about and to tell the patients. For example, if the pituitary surgery is done, we should tell the patients that if they have a macroadenoma, and I know here you do, but there are a lot, we see patients a second opinion that they were never told that the likelihood of cure is pretty low. They were like, you go to surgery and that's it. So if it's lower likelihood of remission, I usually start prescribing medications, even if they don't get it, just to go through the insurance, because I don't know how it is here now, but in our area, it takes several months to get approval for a lot of these drugs. And then if the patient is very sick, then we start medical therapy without radiation because then we can reevaluate for surgery. And then for the type of medical therapy, we also think in detail that I've seen also patients that have started medical therapy and it was continued long term, but if they have poor response or intolerance, then we have to think back to either repeat surgery or radiation with bridge or BLA. I have to say I do it very rarely now, unless the woman want to get pregnant, because again, we have so many medications that if one is not working, we can do. And then definitely monitor for cortical shock tumor progression, even if it's not medication itself and it's natural progression. Several of the adrenal steroidogenesis inhibitors do not affect the pituitary level, so that could be an issue in itself. So this is all I'm going to say about surgery. Pablo, if you're on the line, sorry, but yes, it's first-line treatment for Cushing's disease. And the meta-analysis of published outcomes for first-line surgery, this is from centers that are very, very good because nobody else is publishing the data. So the mean remission rate was great, but keep in mind that this is just from very large centers that are publishing the data. And even then, the recurrence rate, as you can see, was on the high side, but if we look at data, individual data, including ours, you can see recurrence because, you know, the older you get, the more you see patients. And I've seen patients that already had recurrence since I'm there. So it's up to 20% over lifetime. And there are some studies now, because we're following the patients more, that could be even more than that, up to 28% in meta-analysis. So I think what changed is how we follow and monitor for recurrence. Because what we used to do for years, the patients will come and say, I have some symptoms, and we'll be like, your urine is normal, this is not Cushing's. The fact is that's not correct, because you can have recurrence, definite recurrence, with normal urine, and usually the delay in between that, and I have patients that I treat just on the basis, if they have, of course, symptoms and features, just based on late-night salivary cortisol, which makes it complicated for follow-up, but we'll talk about later, because the 24-hour UFC, it's very good for diagnostic, and even that has a problem, but for recurrence, it's very, very late. So that's important to think that probably this is what changed some of the numbers too, because if we're waiting for urine, they might not become abnormal overall. So can we do something about these remission rates if we look at better imaging? And this is a recent systematic review from neuroradiologists looking at a very large number of patients, which again, the tumor detection was better than we think. In my experience, we miss a lot of tumors on MRI, or it's a different reading. And the sensitivity for microadenoma was 70%. And it's possible it's getting a little bit better with specialized imaging, with FLAIR, with 3D spoil gradient. We do all of this, and still we have patients that we can't find the tumor. So overall, we know why this is a problem, because increasing remission is higher if you see the tumor, which makes sense. The surgeons usually look around for it, but still it would be nicer to be there. This is the data from UK. We try to get this in US. It's not approved, methionine PET. So unfortunately, we couldn't do it. Even research was a very complicated step, or having a collaboration with Cambridge. But this is something that they looked at to really try, in addition to the MRI, to see if it's improving the detection. And if you see here that you don't really know if it's on this side or on this side, it's possible that it's improving for, but it's 7 out of 10 for diagnosis, which again, you saw that even the MRI was 70%. So I think for diagnosis, the NOVO is not going to make a difference. But for recurrent cortical tropicominomas, when we send the patients to repeat surgery, I think it's going to make a difference. Because again, how do you know if it's here or here? So now with the uptake of methionine, wasn't perfect, but at least it added something to trying and finding the tumor. So I just wanted to give you a flare in case this will get approved and we can do it. It's very hard. The cyclotron has to be like 15 minutes near the center and all that, but it's super complicated. It works in Cambridge, but for us just going up with a tram, and it didn't work, so that was complicated. So how about that topic? I'm not going to talk too much about it separately because all the meds are the same, but I wanted to really remind you that if the patients are very, very sick, especially and these are the patients with ectopic, while we're still looking where the tumor is and what's happening and what type of therapy do we need, we have to think about initial medical therapy. I have seen many patients in the hospitals before being even transferred to us, kept there for days and trying to find where the tumor is coming from. Once you know it's Cushing's, yes, you like to find where the tumor is coming from, but ideally you also have to treat the patients. Again, if we think that we need IPSS, I'm holding on that. But if the patient is really sick with high mortality, that's something that we can do in a few days also and try to treat both comorbidities and medical therapy overall for days. So which are the medications that we have for patients with all types of Cushing's in general, and then of course the pituitary gland ones are just for Cushing's disease. So we're having meds working at the pituitary gland, adrenal gland, and glucocorticoid receptor. So out of the drugs that work at the pituitary level, which we would like something even better to shrink the tumors, and we're not there yet. The only one FDA approved is Pasireotide. We use sometimes cabergoline. It's not very powerful and extremely rare for ACTH carcinoma. We also use temozolomide. So what do we know briefly? I'm not going to review all the studies. I'm going to give you points for some of the drugs. So for Pasireotide, there are several studies for sub-Q and for LAR that look pretty similar. So for LAR, which is once a month, different doses, that's what I tell the patients. If you have mild disease, the likelihood of responding is about half. Just for mild, for severe, it's totally different. However, the hyperglycemia is very high, which means that if they have diabetes, we need to increase the doses. If they don't have it, we have to watch very closely. So we have to think in advance both of advantages. Yes, I can control it. It's once a month medication versus also your risk of diabetes is pretty high, which again is higher even than acromegaly for the same type of drugs. And it's also some more severe in some patients. If I have a macro that keeps growing after several surgeries, of course I'm going to use it, but just we need to see. And when we looked at this, this is for Pasireotide LAR, and now we have this data published also for other drugs, both for Pasireotide sub-Q and Osilodrostat this year. It's very good, but there were very few patients in the study because that's how was the design. If you have controlled both, so look at blue, control both urine and saliva cortisol. These were high number of patients overall, but very few had control of both because the primary endpoint in this study was urine. If you have control of both, then clearly the systolic blood pressure, the diastolic blood pressure, the weight were more so improved or normalized. So the issue is, are we doing enough if we're using as a marker just the urinary free cortisol? It's hard to say. Probably we should do both. Looking at the data, but we need to look at this prospectively. Looking at the data when we already had a primary endpoint to increase the dose to improve the urine is going to be very hard to make a decision. However, this is a patient working at the pituitary level. You can see tumor shrinkage. So this was a patient that clearly, look at the shrinkage in several months, even without surgery. So some patients will respond well. But if you look at the meta-analysis, there were very few patients that had tumors that were seen on the MRI, especially macroadenomas. So yes, it's proportional responders overall, but we don't have enough data. So I wouldn't do it for tumor shrinkage before surgery unless the patient really has a contraindications for surgery. After, it's a different story. So as a summary, we think that it's controlling 50%, improves clinical signs and symptoms, reduces tumor shrinkage, but it's not important in all patients. Side effects, besides the hyperglycemia, are very similar with all the other in the group that we know for a long time. Blood glucose level should be monitored. And we know now, and you all know, and for the fellows it's on the boards probably, that in addition to inhibiting the secretion of insulin, we know now that it's also inhibiting the release of GLP-1 and GAPs, which is clearly making things worse.
So let me ask them, this 50% response rate, this is after the surgery?
So some of the patients were naive in that study because the study was also in Europe, but the large majority had surgery before. The issue is, even without surgery, if you are responders and you don't really know, and I didn't show you the data, presence of receptors does not really predict response. So it's not like an acromegaly for type 2, but I think that has something with how not good, not to say bad, we are insane for type 5. For type 2, it's much better.
People tried GLP-1 agonists.
Yes, so there are several studies in healthy volunteers worked amazingly well. In patients, I think it's also, and that's one of the reasons why the Cushing's it's worse than acromegaly, my opinion, that it's also an effect of the insulin resistance. So we did and predicted even with metformin, we have some patients and the GLP-1 helped a little bit, but not as important, significant. So it's a corollary of mechanism that the Cushing's, and I think it relates to duration of the disease and how beaten was the pancreas by the high cortisol and so on. So let's switch gears and talk about the mainstay of therapy for all types of Cushing's and the drugs that we have now available. And as you can see, and why it's important, not just to show this graph to us, the students and the fellows, I have to say that I did not like this graph at all in medical school when we had to go through, and now I'm suddenly passionate about. But what the reason it's important is that the adverse effects that I will show you after that will also depend efficacy too, but mostly the adverse events all depends where the drug is working. Is it increasing the androgens? Is it decreasing the androgens? And then, of course, we thought we know, and then longer term it's different. But I'm going to focus on the two drugs that are FDA approved and show you the new data. And of course, I will be happy to answer questions about all of them. So the first study for Levoketoconazole we published now many years ago again, but we have new data and I'm going to show you. This was again related to Mario's question because the study was done in Europe also. 30% of patients did not have surgery. So it was Cushing syndrome, so not all of it Cushing's disease, but 30% was primary medical therapy, which again we don't really do here. So if you look at the response rate, this was without up titration, was 31%, and longer term was a little bit more. But what I wanted to make a point is that even with these are overall results, even with this relatively low number just for urinary free cortisol, you can see that the acne improved, the hirsutism improved in women, the peripheral edema, and also other clinical signs and symptoms. So yes, we need normal numbers, but we also have to look, and that's why my talk was beyond just numbers overall. The most frequent AEs were nausea, hypokalemia, and headaches. You are going to see that in everybody. We have no way in the studies to decide which one is adrenal insufficiency or withdrawal unless they go to the hospital, which again, it's hard to say. For Levoketoconazole, similar with keto, liver enzymes and the QT prolongation are seen, and that's why the FDA had warnings on it. So I tell the patients that we have to follow very closely overall for all these type of symptoms. Before approval was another study where we looked at randomized withdrawal because again in Cushing's, but as you know, it's FDA request for this, but in general, there are a lot of cyclic cases, which even with severity we can see. So to determine control, either placebo upfront or randomized withdrawal, and I'm going to show you some different designs for other drugs. But looking at the proportion of patients with loss of response, so these were everybody was controlled and then switched either to placebo and they lost control as you can expect, and then on Levoketoconazole was about 40%. So that's again what I quote to patients, that the likelihood of response, and then we're looking now in more data. I will show you the abstract soon. And then there were some changes in cortisol related cholesterol also, especially for LDL. It was significant increase with placebo versus levo. Again, these are markers for studies. We're not going to say that the drug for Cushing's would actually improve more than a statin or any other type of drugs, but we look if the patient has other comorbidities, but I wouldn't do for that. So when we're looking at, we publish this data further, but I think that what's important would be, again, to know the likelihood of which dose they will need, how high you should get, the same thing that we had for Pasireotide, that if it's mild Cushing's, you see response 50%. Here it's very hard because, again, some patients didn't have surgery and that several studies didn't have up titration pushed significantly. But overall, it's the same message. If you have baseline UFC that's a little bit lower, you are going to require lower doses to achieve control. So that's very important. Again, when we see a patient in front of us, which drug we're going to start, in addition to my favorite one, then the insurance says, no, start with the other one after I put an hour's thought in what would be the next one to actually use. Furthermore, and I think for Levoketoconazole, it's even more important that the liver-related AEs were also lower with a lower dose in patients with significantly lower UFC. So I think that's important to also think about. So in general, for this drug, I start with 150 BID and titrate very, very slowly. And then definitely, because the liver enzyme was seen in 31% of patients, liver enzyme elevation, I really follow, I rarely look at the FDA indications like when do you have to do the liver panel, when do you have to do the EKGs. But for this drug that I have warnings, I actually follow it closely overall, and I have several patients that are doing well. Switching to the other drugs, when I'm going to show you more studies, because this was a drug that it has been approved now since 2020, and we started with studies. The proof of concept I'm not going to show you, but the link to, we started almost 10 years ago, if not more. And we had patients already, very few patients, but we had patients that were treated for 282 weeks. And then a larger studies that we published extension now a few years later, there were more than 100 patients treated for a median of 130 weeks, some even more. So the method for this drug, and I'm going to show you some more data of finesse, is that these were very severe. Some of them had very severe Cushing's. Look at the in UFC, almost 10 times upper limit of normal. So this was also, at the beginning, we started, that's what happens in phase 2. You start the patient that you really want to see control. So it's a little bit of bias how high it was. Though this was a much larger international trial where they started pretty high too, but this was like the median was 1,000, here was 1,400 millimole. Everybody still high. Everybody decreased, and some of them normalized, and I will show you the data, and persisted longer term. And this is also the one that's my favorite one, because we show the patients that you have once, because everybody's asking, this is a new drug, am I going to take it? Am I going to remain controlled or not? And as you can see, 81% of patients remained controlled overall. So I think this was clearly showing the long-term control, significant improvement, and we have several papers coming out, and one was last week. I'm going to show it to you, or last month. What was interesting, and I don't have super details in slides, but I'll be happy to show you, based on mechanism, the testosterone goes up initially, but very interestingly, longer term decreased in all patients. Of course, with longer trials, some of them, so it's possible that some women with severe heart disease will drop, but still, even the levels of testosterone decreased towards baseline back, which again, I hope you're not going to ask me because we do not know. What was also very important is that the median average dose was 7.4. So that's why we need long-term studies, because keep in mind, we push these patients, and that's why I will show you the adrenal insufficiency rates. We wanted control, especially in link 2. And when we did a study design, we wanted everybody controlled as fast as possible, of course. So we pushed the doses higher and higher. These patients longer term do not require a high dose. If they we leave them on high dose, they will have more adrenal insufficiency. So we have to up-titrate very slow if we can, but it's hard. Once you see something is working, you push. So the other study that was with placebo up front, this was the percent of patients improvement with a drug versus placebo 8%, which again, this is not that the placebo works for Cushing's, this is just the variability of cortisol. The reason I had this was to show you that even in a short study of 48 weeks, we see that the Cushing's quality of life improved and the depression score decreased. Means that patients that even some of them again here failed surgery, very few were naive overall in this study, but you can see clinical improvement. Am I going to use a drug just to decrease the depression score? No, but I like something that the patients will feel better also, in addition to improving the cortisol if I have a choice. Sometimes I don't. So I was talking to you about the titration schedule. So how we did it in link 3 was increase every 2 weeks. from 2, 5, 10, 20, and then 30 BID. Because in link 2, we used up to 50, then it was stopped. And I have to say this was clearly wrong, but this was out of, we wanted control. And you know, when you sit in a room and you design a study, you want to have control as fast as you can, which clearly was, we're not used to a drug that was so important, let's put it this way. And then for link 4, the increase was every 3 weeks, and this made a difference for the reports. Again, these are reports of hypocortisolism related events, so not all of them were adrenal insufficiency. A lot of them were withdrawal, but we don't know, because if you don't have a cortisol that's low, and even then, if it was done in clinic, keep in mind that both for Osilodrostat and the metiraquone, the type of assay for measuring cortisol is important. So if you don't have LCMS, the cortisol, because of the precursors, is going to be falsely looking normal, so the patient can have adrenal insufficiency. So this is why for a lot of them you see hypocortisolism related events, because really we don't know. So my job right now would be to convince you that we should initiate at the low dose and then wait. And even now, after I know all this, it's hard because I want to see response as fast as we can. But adrenal insufficiency could be severe and it happened in a lot of patients. And then, of course, this is long term. We have to look for all the drugs.
How do you deal with adrenal insufficiency?
So I do, that was on my next to decide a little bit for ectopic. I just use higher dose and do block and replace, which we did not do in the study because in the US, I have to say, because it's CME, it's approved just for Cushing's disease. That being said, I'm using it off label for a lot of other types, but it's not approved. Levo is approved, Levoketoconazole is approved for all types of Cushing. Osilodrostat is just for Cushing's disease. So I use higher dose for ectopic or adrenal cancer, where I'm using, again, off label. I use block and replace from the beginning. So I give them 5 BID for most patients, even in the hospital, controls them pretty fast. And then I like to give them Dex because then I can measure the cortisol and see. Instead of hydrocortisone and in the hospital, you can hold it. We've all been there. You say hold it, they don't, and so on.
But
So
for
Cushing's disease though, I still try to do, but I start very low doses, and I have here with even lower than the approved one. So I start with 1. So these were several cases being off label. I have mine too, but being off label, I decided to use for a CME papers that are published. But as you can see, this was a patient intensive care unit, which is very funny. Look at how many days they were staying just for this.
Right.
Our institution does not give them more than 24 hours. If they can breathe out on the floor, and we treat with a drug there. That's one of the reasons I don't use Epidemiology anymore, because we don't have enough beds for ICU. But you can immediately decrease the cortisol. This is in green from very high number. So, but again, how do you know what for a patient that's going to be sick anyway? Without block and replace, I would not do it. And this was a patient with adrenal cancer, where again, they use hydrocortisone, and I use long-term hydrocortisone too. So if you're interested, yesterday we published a paper with how to use Osilodrostat as a practical cases, and we have several examples with all our cases too. So how about, this is the one that I said it was, I think now last month already, because it's March, where we looked at clinical improvements. So this was a combination of all the studies that I have shown you, where we looked at glucose improvement, and as you can see, and then also diabetes. So these were patients that were on medications for diabetes, but several of them did not have diabetes. If you're asking me, even at bad Cushing's, they didn't have diabetes, so we should look at what's protecting them from that, but that's different. And then this is the improvement overall. So you see when you start with a drug that you see some improvements, but what happened, I think, also is patients being in the study, they are also monitored much more closely. So it's hard to say, but overall, the patients need improvement of clinical features. Can we get additional ones of just from one drug versus the other? I don't think we have any differences. Just we have more data because here we had more study. This is for hypertension, where you can see a more dramatic response. However, I think controlling the cortisol, and it's more important, for example, for testosterone to look at Levoketoconazole. It's actually decreasing the testosterone. So in men, it's going to be better at the beginning and so on, rather than for these comorbidities with yes, we see very nice graphs, but does it really make a difference from clinical improvement? I'm not sure. So I don't think we can say that, but it's important to look at. So this is the summary, Mario. You jumped, but that's how I usually do it. The label says 2 milligrams. Most of the patients they start on 1 milligram. This is for Cushing disease. Again, for ectopic, it's totally different. And then titrate no more frequently than every 2 weeks, but usually I do more than that. Maximum recommended dosage is 30 milligrams. We have used higher doses, and I had some patients in initial studies, but we don't need it. And risk of adrenal insufficiency overall is still high because it's a potent oral inhibitor. So I just want everybody to think that the patients can do well. They're fine. It happened to us in COVID. They're fine, fine, fine. We give them hydrocortisone to go home on to take it if they're not feeling good. But then at that time they got COVID, and then all bets were off, even with hydrocortisone. They needed injectable and so on.
Dr. Fleseriu, do you
Yes.
see them every 2 weeks in the
No. So what I do is, we also are a very large state, so we do telemedicine, and I have a license for Washington, and then the other drive to the border. That's a different story. But how I do it is I check a cortisol in 2 weeks. I send everybody home with hydrocortisone and injectable steroids, the same thing as for adrenal insufficiency, just in case. And I do that for Levo also. For Pasireotide, just because it's not so potent, I didn't do it. And then I do a cortisol 2 weeks in the urine. And then if we can at least review the results and send them on my chart. If they don't feel well, we set up a telemedicine appointment with our team, usually not me. And then in function of the labs, I see them at 1 month. But I'm trying, so I do the morning cortisol mostly to see the saliva cortisol to see how it's working and to avoid adrenal insufficiency. And then the UFC I do 3 to 4 weeks because I'm trying to actually have it before I'm planning on increasing. The UFC decreases can decrease fast, but my job is these patients have Cushing's forever. So I want to make sure they don't have adrenal insufficiency first. So the morning cortisol, that hazard is that if they are not coming to us, I need an LCMS lab for cortisol. So some of the local ones don't. So when you send it not to your, I don't know what you use here, but you need to know the answer. So locally, if they go wherever they want, it's a hassle because they have to call the lab and find out what they say they have and so on.
That's a lot of lab data pouring in for your patients.
Yeah, that somebody has to review. I know.
Yes.
True. But they're doing very, very well. And I have some patients that were in the studies, so they are on the drug for 12 years. So, and they're doing so well, and they've had surgery before and all that. So, okay, so let's switch gears and talk about the last drug that it's a glucocorticoid receptor blocker, mifepristone, that has been approved now for many, many years. And this was the first study that we have published, very small study, but for that time being first, it worked. 43 patients with Cushing's disease, Cushing's syndrome, who failed multimodality therapy. Again, keep in mind for the fellows, if you block the glucocorticoid receptor, you cannot measure cortisol. You can if you want, but it's not. It's going to be high. I had many patients sent from other hospital and even ER home with no adrenal insufficiency because the cortisol was normal. So this is a little bit scary. So we look at improvements. This was based on A1C, and you see here, this was significant improvement even with patients, with some of them decreasing insulin in half or even stop it at that time. And then clinically, the same thing. Without cortisol, it's hard to say. Because as you can see, much improved it in red. So over time, many were much improved, but there were a lot of them that had no change either. So it's hard. I put the name of the talk as beyond biochemical control, but I still love the cortisol value, and I know to have it. However, for severe patients and patients with severe diabetes, we use this drug also. Overall, we had the doses are between 300 and 1200 The large majority of patients were on 900 in the studies, improved glucose and clinical signs of symptoms. What I wanted to point out, talking about adrenal insufficiency, is that keep in mind that if you get a call from outside on this, yes, of course, cortisol level cannot be used to evaluate efficacy, but also not for adrenal insufficiency. And the doses of dexamethasone they need to replace the mifepristone from the receptors are much higher than we usually use for adrenal insufficiency. So that's something that you have to remember. Yes, there can be some thyroid dysfunction, including primary, with some direct effects on TSH. You know more about that. That a lot of patients will become hypothyroid, but I think that's the most important thing. That the precursors can also induce adrenal insufficiency. So they need higher dose of dex and then few more days than we usually use for other drugs. So, okay, so summary and practical considerations before we go to questions. So I entered some of them because Mario was in a rush. So what I want you to, the practical consideration, I want you to think that the reason we're not doing well overall is because we do not have a good definition for measurement of glucocorticoid excess. So there are a lot of factors affecting cortisol level. How we measure it has its own problems. Overall, there are some new markers in studies that have been used, but none of them are great. So we still have to use overall the one that we have, the urine, the saliva cortisol, and then of course we use for diagnosis the overnight X, but we can use for follow-up the drug. So some of the issues that I showed you with variable response is due to that. Now also what we don't do well, this is a survey of the patients. Have I shown you something about weight? Minimal data. Look at the weight gain was the symptoms most often ranked as the top 3 most burdensome symptom by patients. So we're not doing, based on this, as you can, this is like over 200 days and this is smaller. So look at the acne, how important it is for patients. Look at the heart disease. Look at all these others that I barely showed you in the data. I have the data, but minimal for this. So I had to look to do new slides when I saw this just to see how it works. So matching of what we do when we focus on cortisol versus what the patients need, it's very different. And then also we need, assuming we have all the medications, we have to look more holistic at the individual patient's characteristics that we don't have so nicely as for acromegaly. Concomitant medications, which again, especially for QT, is very important for a lot of drugs. And then efficacy data to know the numbers, but to know the numbers more in finesse, in addition to the primary endpoint, which I try to show you patient preference, injection versus oral, and of course, severity of hypercortisolism, which is very, very important. So before we are done, I wanted to show you, and I'm not going to go in super details, we tried, and out of more data sets we published in this review, we tried to look more at predictive response for biochemical response, and I already have talked to you about that. I didn't show you the USP mutation that shows that it's improving Pasireotide response. So the receptors don't seem that matter, but if you have the USP mutation, which again is rare, it's improving response, but also predicts Cushing's recurrence. Of course, if you have abnormal baseline glucose, you have increased risk of hyperglycemia. And then this was just based on observation. We have no data in paper, but it's my clear observation that if they had long-term Cushing's, they have more severe withdrawal, and this makes sense. Why is it psychological? We don't know. And of course, the hepatotoxicity related to the lab. So how can we individualize? Of course, comorbidities and complications, and I don't think we're doing a great job, but we're improving, and we have to focus especially more on hypercoagulability, but also on cardiovascular disease. We have to monitor MRI for tumor mass progression much more closer than we do it for if they are on these drugs, especially with the exception of Pasireotide. And then, of course, the decreased disease morbidity and mortality. The mortality is a wish. We have data that it's improving, but maybe because we are using less radiation. I'm not sure that we have data separately just of the medical therapy itself. We have several new drugs. This is a partial list. Relacorilant completed phase 3 trial. We have several drugs in phase 2 trials that hopefully we'll see the data relatively soon. And then it's a proof of concept that you have seen in an abstract with a selective ACTH antagonist. So things are coming. Now, how much is going to improve clinical features? For example, this one is going to be block and replace because it decreases cortisol and agent antagonist within days. This was done at NIH. Within days, it was like almost non-existent. So, yeah, exactly. So I'm hoping that we can take these patients with persistent disease, most of them will be after surgery, especially in US, and then based on all these individual clinical attributes and numbers, not just numbers, we can decide which drug is best for which patient. And with that, I'm done, and I want you to show you. These are some pictures from my fellowship. It will be on there too. So I don't know, Dr. Feynman, if you're on the line, but okay. See, I promised you. And this is my program director in my first year, and he hired me. And then you'll see my program director soon. Look, Maria. Yeah. Show it to her too. Yeah, exactly. Yeah, we all were. We look exactly the same. Eddie, Linda, see? Okay. And then this is my other co-fellows at the time. And this is my last year program director, who gave me a great recommendations to get the job in Portland, where I am for almost 19 years. And Bob will look exactly the same too. Thank you so much. So on the left is Portland, and that's how we go with the tram. And that's why I said, and I wasn't joking, because the hospital is up here, and the clinics are here, and the cancer center and the university, literally, this was one, then we couldn't do it anyway, because it wasn't approved, but this was one of the issues that we could not see the patients here and then send them to the machine because it was more than 15 minutes. And here is my city in Romania, in Sibiu. I'm from Pennsylvania, so I'm a vampire. That's why I can always laugh. Thank you so much.
Thank you. I will say one thing, that the pituitary field has really developed in the last 15 years, and I'm glad we have Dr. Yogi Moran to send all these patients. Because I do not want to see those labs, and I don't want to know what to do.
Especially when you saw how many we are.
Oh yeah, every 2 weeks, the obesity people are a little bit easier, even though the counseling is hard. So we have a ton of questions coming through. The first one is, at what serum cortisol level do you start hydrocortisone?
So that's my favorite questions. I don't use serum cortisol to start unless they have symptoms. So if the serum cortisol done in a good lab, you assume on meds. Then the question is on meds. I use the 5 to 7, but they have to have symptoms.
And this is the 8 a.m. blood draw.
The 8 a.m. blood draw. If they don't have any symptoms, and I check the cortisol, and it's just 7 with no symptoms, then I don't start hydrocortisone. I just dial down the drug. If especially the urine is normal. For Osilodrostat, for example, I dial down the dose rather than starting hydrocortisone for Cushing disease.
So you trust the 24-hour urine cortisol a little bit more than the serum?
So not for GI insufficiency, but it could be the morning cortisol, and you can do stimulation on meds. The morning cortisol is very, very low. So if it's extremely low, it's fine. So again, if it's LCMS, if it's not LCMS and I have a 5 or even a 7, then I would panic and I start hydrocortisone. But if they don't have symptoms, they are now into develop adrenal insufficiency, and you can decrease the dose of Osilodrostat. So because the goal would be to decrease the dose of the most expensive medication rather than give them hydrocortisone. For ectopic, I don't play with that. I just block and replace and done.
Is there a future for ACTH receptor blockade for Cushing's disease?
So that's a very good one, and that's why I showed you a little bit as that it's coming. So was a proof of concept. It's not published yet. Has been presented at Endo, showing that sick patients decreased its IV. They were inpatient, then IH, so that's much easier. That's the one I can open at the clinic, but it's without block and replace. Increase the cortisol immediately. So do I see a future, especially for ectopic or severe cases? Yes. For minor cases, I don't think so, because I still like not to use block and replace if we can decrease to normal, because we don't know. I showed you just the problems we have with Cushing's, that we don't have any markers, but we don't have good markers for how much hydrocortisone they need either. So that's a problem. We know we're over replacing. look at the kids, they're coming kids, and then we increase the dose just because they turn 18 significantly. So I think it's an issue overall that we need to if we go that route, then we need way more studies for markers of glucocorticoid excess, because I think we are over-replacing a large majority of patients, and that's what's one of the issues of mortality for patients with hypopid.
I think my chair in internal medicine when I was a resident used to say that everybody gets better with steroids doesn't mean they actually need steroids.
Exactly.
It's the same problem even after Cushing's treatment. We don't know how much it is to give.
Exactly, and for withdrawal, and you are correct, with withdrawal, if you give steroids, they will feel, but that doesn't mean they have adrenal insufficiency, you just give them back the steroids. What I tell the patients when they leave the clinic is, even before surgery, that the steroid is so powerful that they actually, and I'm not lying, they did studies with high dose steroids to take people off cocaine. So there have been studies that so the withdrawal is really withdrawal, especially at the brain level. So when they tell them that, maybe they are a little bit more inclined to suffer. But it's a real problem.
Christina, can you unmute Dr. Yogi Moran? She has so many complicated questions that I'm going to let her ask them herself.
Thank you so much, Dr. Fleseriu. That was an excellent talk, and I do have lots of questions. So one of the things when treating these patients with Cushing's, if they're on Isturisa or any adrenal enzyme inhibitor, they're asking questions about data on long-term safety. And I don't know if I know you have been a PI for a lot of the LINK studies and a lot of the research with these medications. What do you tell patients who are concerned about the long-term effects or possibly being on these medications for many years, possibly the rest of their life, about their concerns about prolonged use?
This is a great question, and I can show you all the data. But I think right now, talking about drugs in general, for Osilodrostat, we have the longest term data for the largest number of patients. So we have in the extension data, we had over 100 patients followed for several years, and in Link 2, we had even for more years. So what's, again, the final paper with everything else has been submitted. I can't tell you when it's going to be published. Hopefully you're not a reviewer because you'll have more questions. But we have not seen anything different long-term than short-term, with the exception, there were two issues, and I didn't have slides because I can tell you because I presented it as a poster and an oral in Europe. So what was interesting is the type of effect, adverse effects over time change. So the beginning was more adrenal insufficiency because also we didn't know how to use it. But then if you look even years later, the patients still can have adrenal insufficiency though they were on a stable dose. One, because usually they need lower doses, so we have to do a better job in decreasing the dose later on. And then second is they got sick with something in between. So that's why I give them steroids to begin with, to have at home and be like, if the kids are sick, don't take it yet, but just watch it. If you are sick, then take it immediately. And then if you're much sicker with flu, stop the Osilodrostat, take hydrocortisone for a few days, but call me in between. But I don't want them to call, and then by the time the message gets to me, they could be in crisis. So I prefer them to have it at home. What we also have seen, and I can tell you because we did that for mifepristone in the longer term data for Levoketoconazole, we see tumor growth over time. But again, it's very hard to say if this is just because you are blocking the adrenal steroidogenesis. Is this natural history because you follow these patients without a drug that works at the pituitary level, and we didn't have so long-term data for Pasireotide overall, but that's a different mechanism. So something more frank over time, even without radiation. So that's something that I do MRI. The problem with correlation between ACTH and MRI, and we looked more into that for Levoketoconazole, for mifepristone, the ACTH will go high, clearly, because you block either the receptor or you block the enzymes. But is this a correlation with the MRI itself? It's very hard to say. For mifepristone, for example, the macro continued to grow, but there were 3 cases in the study and didn't have any direct correlation with ACTH. For Osilodrostat, also, if you look at the EG paper, that it's the extension study with more longer-term data. So it was increased, also decreased. Some stay the same. What I personally do, if the ACTH is getting significantly higher, then I will do an MRI. I can't say, and we didn't publish the data, that it makes too much sense. But also I have some patients that I have a combination of Osilodrostat, Pasireotide, and cabergoline, and the tumor keeps growing. But this is not a drug. This is why the patients came to me, because they had all these things. And I don't think the tumor, for the large majority of patients, I don't think the tumor is an issue. It's just what we see. Definitely, we have to pay attention.
So that brings me to the next question, which is about, since you mentioned Pasireotide and cabergoline, and so when patients are on these drugs that act at the level of the pituitary, do you ever, or do they ever, discontinue the medication because you want to see if their tumor control is maintained? I do have some patients who, self-discontinue these medications and have remained for a couple of years now, eucortisolemic, but wondering what your thoughts are with these medications. I think of the prolactinoma patients where we treat, if their tumor size was initially small, where we treat with a dopamine agonist and then after 2 years might consider a trial of withdrawal. Do you think we can extrapolate that to patients with Cushing's who are on Pasireotide?
I don't think we have enough data for that because none of the studies told them to stop and then follow them after that. I'm sure some of it is variation, and later on they would be, so even if the tumor decreased significantly, in addition to the big cyclic Cushing's, variability of UFC is 50%. So can they have just mild Cushing's and you think they're fine if they discontinue because they have normal UFC, or all their other labs, including saliva cortisol, are normal and clinically they are fine? I don't think that we have good data for Cushing's that it's cured itself, like for prolactinomas, unless the patient had hemorrhage. So if it was pituitary apoplasia, and we know with the Pasireotide for acromegaly, you can see some direct effects on the tumor with apoptosis. So it's possible. I'm not saying it's not possible in some patients. We had 1 or 2 ever, but again, I don't know if we can say this, that we can stop. And look, you are not old enough, but look at for the prolactinomas, how many patients we stop because the initial paper said stop it. If it's nothing on the MRI. And the recurrence rate was so great at 2 years, but then longer term, almost everybody had to go back. So I'm not sure how, and it's the same thing for acromegaly. Some patients can be off therapy for a while, but I don't think for Cushing's, I decrease the doses. For Osilodrostat, we have patients that are not taking the drug for several months, and some were even published. So that's a different, it's a blockage of the enzymes for a longer time. But I don't think we can say we can stop the medications and the treatment. And especially, I don't want the patients to think that they can stop it in advance. If it happens, it happens. But they need to understand this is long-term therapy unless they have radiation.
Thank you so much.
And we have enough data for long-term, at least for now, until something shows up, we have enough data.
Thank you so much. I'm sure I could ask more questions and we can talk all day, but I'll stop for now. Thank you so much, Maria.
Thanks.
Thank you, Dr. Yoginoran. Dr. Rao, would you like to unmute yourself? Again, complicated questions that I don't understand.
Okay, no, thank you, Winnie. Great talk. Thank you, Dr. Fleseriu. Enjoyed it. One question was, have you used mifepristone in combination with any of the newer medications, and what has been your experience with that?
So I have used mifepristone. It's not FDA approved, but of course we still use it if the patients were on it. I have used it personally with Osilodrostat, with ketoconazole, and I have used it. But again, there are very few patients, so I wanted to show you not just my data, like N of 1 or 2, mostly what we have data on. The paper on mifepristone, that's why I didn't show it yet. One, because it's not FDA approved and I had to cut something, but also that the prospective data was a poster 4 years ago and the paper was never published, with response rate of about 14%. So since it's pretty similar to Levoketoconazole, the dose was not so, and most likely less potent than Osilodrostat. And now we know, and there were a few studies done in Germany, retrospective, that it's less potent. and also with more hersities, probably, though it's also an 11 beta hydroxylase inhibitor, the affinity for different enzymes is a little bit different, probably. Again, we don't have clear proof. But if the patients were on metirapone before, of course, I continued. I don't change something that's working. And I have used it in combination. And in the hospital, it's much easier to get it than Osilodrostat. Probably because of cost of pharmacy. So yeah, on a lot of ectopic, I start the same thing like I do for if I have the Osilodrostat for ectopic in the hospital, I start metirapone in combination with keto, just because I can get them that day, and then and initially I want to see how they do both potassium and QT interaction. So I do an EKG every other day. I do liver panel, I do BMP because then pump a lot of potassium because usually they are very hypokalemic. And then do block and replace with Dex so I can measure. So I can go on the doses much higher, but they require very high doses.
Yes, perfect. Thank you, because that's what we have been doing too in the hospital to get these ectopic or uncontrollable ones under control. We've done metirapone and ketoconazole combination, and that seems to work beautifully.
This is a CME. That's none of them are approved, and none of the combinations are approved. So my job is to tell you what it should be done, and then what we actually do. Yes.
Yeah, and that's why I wanted to ask you, because I knew they were not approved, but we've had such great success with this combination, especially in the hospital, to bring it down acutely. And then outside, of course, then we try to do the Osilodrostat.
Yeah, exactly.
And my next, thank you so much. And I'm glad to hear that, we are doing the similar things about that. And my next question was, do you have a preference between Levoketoconazole and Osilodrostat, or do you, is it more about whether it's a male or a female and you don't want hirsutism and things like that? Or have you had any differences in your experience?
Usually the preference is insurance, which again, I'm not a fan of, as you probably figure out. So if in general, how I think about, if somebody has no liver issues and it's a woman that it's bothered by, because now long-term, I'm not so worried about the increase in testosterone with Osilodrostat, but short-term, it's clearly increasing and some can have more hirsutism. So if it's a woman with mild Cushing's, with no liver issues, no history of alcohol abuse, which is bothered by hirsutism, then definitely I would like to start that because I know that I can control it even at a lower dose. On the other side, if it's somebody with severe Cushing's, then I know that I can control better with Osilodrostat, and then I tell the patients, hey, yes, hirsutism is probably not good, but looks like what I want and what the patients want is very different if you remember that graph. Weight gain, they see that they're so bothered by weight gain. I think that they have, especially with Osilodrostat at the beginning, they don't see so much weight loss because, it's aldo. And they have some swelling. So again, if I think that the weight is an issue, also I would like to start low dose of Levoketoconazole and then switch after that. Stammer, I say, I think you'll do great with Levoketoconazole. They look it up and it's like, it has a warning, I don't want to take it. Some says, yes, I want because it's, but I generally, I look at how severe is the Cushing's and also what other comorbidities they have.
Got it. Thank you.
I think for potency, Osilodrostat is first.
Yes.
Definitely in a different league, I think, for decreasing cortisol. Sometimes even too much, as we've learned.
Yes. Yeah, thank you. That's very helpful.
Thank you, Dr. Rao. Dr. Rao is our Adrenal Medical Director, Center of Excellence. So that's why all the any questions from the audience here?
Okay.
If somebody starts a medical treatment and then goes to surgery, how do you monitor the effect of surgery?
So I don't know if you heard the question, but I think it's also very, very important that I have it in the interest of time. In the guidelines, what we said was use preoperative medical therapies for the patients that need it. We also had it in the middle of COVID, the guidelines, so we're more worried about. So we're using it now, though in US insurance, it's hard in getting months before surgery approved, but sometimes I convince them to do it. For Osilodrostat, for example, that we know can have a prolonged effect, I am not using the cortisol in a hospital. I do it, but I'm not using it as a marker for remission. I tell the patients in advance, if we had to use it, and the surgeon is harder to convince them because they want to know that the patient is in remission when they leave the hospital. But I tell them when it's low, it doesn't mean anything. If it's high, it does, but if it's low, it doesn't. Because we have seen patients that this Osilodrostat was prolonged. So in general, I stop it with about a week before. And the reason is mostly because it has drug-drug interactions rather than that I'm worried about the cortisol. I take a cortisol before to make sure they don't have adrenal insufficiency and they will need steroids very off. So we had a patient that got changed and the surgery was earlier, so I didn't have time to get the cortisol. So I stopped the Osilodrostat and I said just give steroids very off because you can induce profound adrenal insufficiency and that would be not good to have a patient go to surgery on the drug itself. But it's complicated. So then I do a few weeks later when we get stopped, I still send them home on hydrocortisone, but I check up cortisol at night. So if it's high, then it's easy. If it's not high, then we say you might be in remission, but we don't know.